All right, ready to dive deep into some fascinating disorders.
I'm ready, let's do it.
You know, the ones you don't hear about every day.
Right, like the hidden gems of the psych world.
But they can be just as impactful for the people going through them. We're going straight to the source for this one, the Handbook of Clinical Psychopharmacology for Therapists.
A classic. It really gets into the nitty-gritty of how these disorders work and, of course, how to think about treatment.
What I always find so interesting is how with these lesser-known disorders, the biological side is often still a bit of a puzzle.
Absolutely. Which means figuring out the best medication isn't always a slam dunk.
So today, we're going to tackle Tourette syndrome, eating disorders, ADHD in adults, even self-mutilation. Ready for the challenge?
Challenge accepted. I think this is super important for therapists, because it really forces us to rethink those assumptions we might have about treatment. Just because something's labeled miscellaneous doesn't mean it's any less complicated or, less of a big deal for the people who have it.
Exactly. And this chapter, it really digs deep into the research, the different ways to approach treatment, and even some of those debates that still swirl around these disorders.
It's definitely not a simple chapter.
Not at all. So let's kick things off with Tourette syndrome. It's one that tends to make a splash in the media, because of those more dramatic cases you see.
Right.
What's the biggest misconception you come across when it comes to Tourette's?
Oh, for most people, the first thing that pops into their head is coprolalia, the involuntary shouting of swear words.
Yeah.
And while it can be a part of Tourette's, it's actually pretty uncommon.
Oh, that's interesting. So it's not just about those outbursts.
Not at all. At its core, Tourette syndrome is all about tics.
Okay.
Those sudden involuntary movements or vocalizations. And those can range from subtle things like eye blinking or throat clearing to, more obvious movements like head jerking or even some really complex movements.
Wow, so it's a pretty wide spectrum.
Definitely.
Yeah.
And what's fascinating is how anxiety and tension can actually make those tics worse.
Oh, I see. So it's like the body's stress response is kind of getting channeled through these movements.
That's a really good way to put it. And the current thinking is that it all boils down to a neurological basis. There's a possibility of, some dysfunction in the brain's dopamine pathways.
So medications like haloperidol and pimozide, they come in because they're dopamine blockers.
That's right. Those dopamine D2 blockers can help to manage those tics.
And I know the chapter mentioned some of the newer antipsychotics like risperidone are also being used with some promising results.
Yeah, absolutely. There are definitely more options coming up on the horizon. But, treating Tourette's isn't just about medication. Therapy can play a huge role in helping people deal with the emotional and social stuff that often comes along with it. Imagine being a teenager trying to fit in when you have these tics.
Right. It's got to be tough.
Yeah, so building up those coping skills and social skills is super important, just as much as managing the actual tics themselves.
It's about supporting the whole person.
Exactly.
And speaking of seeing the bigger picture, I thought it was really interesting how the chapter connected Tourette's to OCD and ADHD.
Oh, yeah, that's a big one.
How some folks actually experience all three. It really shows how much these disorders can be intertwined.
Definitely. It's a really important point, and one that just underscores how complex diagnosis and treatment can be. It's not just about, zooming in on one isolated symptom or condition. We need to understand the whole person and how everything's presenting for them.
Makes sense. Okay, let's move on to eating disorders.
All right.
They're so often misunderstood. These are about way more than just, wanting to be thin.
Oh, absolutely. It goes so much deeper. We're talking about these really ingrained psychological patterns and even potential biological predispositions.
Yeah.
The chapter really breaks down the two main types, anorexia nervosa and bulimia nervosa, and gets into their unique traits and the challenges that come with each.
So let's start with anorexia. What are the core things therapists need to be tuned into?
Okay, so the hallmark of anorexia is this intense fear of gaining weight.
Okay.
And this fear drives people to restrict their food intake really, really severely. We're talking about maintaining a body weight that's significantly below what's healthy, but what's even more striking is this distorted body image that comes with it.
Right.
People with anorexia can be dangerously thin, but they still see themselves as overweight.
Wow. It's almost like their perception of reality gets kind of hijacked by the disorder.
Yeah, that's a really good way to put it. And this makes treatment incredibly tough. You're not just trying to get them to eat more, you're trying to tackle those deep-seated psychological mechanisms driving their behavior.
And then on top of that, the chapter talks about all the serious health risks that come with anorexia, like malnutrition and even heart problems.
Hmm.
It's not just about treating the mental distress, it's about potentially saving lives.
Absolutely. It can be a really delicate balance, you know? You have to think about potential malnutrition, organ damage, even heart complications. It's a serious situation. And it often takes a whole team of professionals, doctors, therapists, and often nutritionists, too, to really support someone with anorexia.
The book digs into some really interesting theories about what might be going on in the brain with anorexia. One that really stood out to me was that addiction to starvation idea.
Oh, yeah, that's a fascinating one. It suggests that when you fast for a long time, it can actually trigger the release of endorphins. And we know endorphins can make you feel good, right? So it's almost like the body's reward system gets messed up, reinforcing that restrictive eating behavior.
So you starve yourself, you get a temporary mood boost, and then the urge to restrict just gets stronger. That's such a vicious cycle. I can see how medications like naltrexone, which block those endorphins, could be helpful in breaking that cycle.
Right, and that's definitely a hot area of research. But the chapter also makes it clear meds alone are rarely the solution. You need a multifaceted approach, you know?
Yeah, because even if you suppress the urge to restrict with medication, you still haven't addressed the root of the problem, like the distorted body image and those underlying emotional struggles.
Exactly. You got to get to the heart of it.
Okay, let's talk about bulimia nervosa now. It presents a whole other set of challenges.
Yeah.
Can you break down the key features?
Sure. Bulimia is all about these cycles of binge eating, where someone eats a massive amount of food in a short period of time, followed by purging behaviors like making themselves throw up or misusing laxatives. It's a really distressing cycle, fueled by a fear of weight gain and tons of guilt and shame.
It sounds incredibly taxing emotionally. But the chapter mentions that medication seems to work better for bulimia than anorexia. Why do you think that might be?
Well, one theory is that bulimia could be a type of depression.
Okay.
And this idea is kind of supported by how effective certain antidepressants are, like SSRIs, TCAs, and MAOIs in treating it. They can help get those mood swings under control, reduce impulsivity, and even address that deeper emotional distress that might be fueling those binge purge cycles.
So it's not about just controlling the eating behaviors. It's about addressing those underlying emotional vulnerabilities.
Exactly. And while meds can be a big help, it's key to remember they're not a cure-all. Therapy is still vital in helping people challenge those distorted thoughts, build healthy coping skills, and develop a better relationship with food and their body.
Now, there's one more eating disorder the chapter covers. Binge eating disorder. How is that different from bulimia?
Good question. So, binge eating disorder also involves those episodes of uncontrollable eating, but there's no purging afterward.
Yeah.
No throwing up, no laxatives.
Oh, I see.
This often means people with binge eating disorder gain weight, and that can make managing their weight really, really hard.
Yeah, it seems like it would take a huge toll on self-esteem, too.
It does, and it's often linked with feelings of guilt, shame, and depression, you know? Just a lot of heavy stuff.
So what are the usual treatments for binge eating disorder?
Typically, it's a combination of things, lifestyle changes, like getting on a balanced diet and exercising regularly, along with medication. Antidepressants like SSRIs and bupropion can help. There are also meds that specifically target appetite. The chapter highlights lisdexamfetamine as a newer option that's looking promising, particularly in reducing those urges to binge and preventing relapse.
It's interesting how a medication initially designed for ADHD is now being used for an eating disorder. It really shows how connected all those brain systems are.
It really does. And that's why having a holistic view of treatment is so crucial. It's not just about squashing symptoms. It's about figuring out what that particular person needs, you know? You have to develop a plan that tackles the psychological, the behavioral, and the biological pieces of the puzzle all at the same time.
All right, let's switch gears and talk about a condition that often flies under the radar in adults. ADHD. We're a lot more aware of ADHD in kids, but it can be kind of mysterious when it shows up in adulthood. Can you shed some light on that?
You're right. We have that classic image of a kid bouncing off the walls, but that might not be the typical picture for adults with ADHD. But those underlying struggles, they're often still very much there, just playing out differently.
So it's less about being hyperactive and more about these internal battles.
Exactly. Some adults might still have that restlessness and impulsivity, sure, but Many struggle with inattention, disorganization, trouble prioritizing things, even controlling their emotions. They might feel constantly overwhelmed, behind on everything, like they're not reaching their full potential.
I imagine that can be really hard on someone's self-esteem, feeling like you're failing but not knowing why.
Absolutely. It's a recipe for self-criticism and frustration. And that's why a thorough evaluation is so important. The chapter really stresses that adults with ADHD often go to therapy for things like depression, anxiety, relationship problems, or job issues.
Oh, wow.
They don't even realize those might be rooted in their ADHD.
They're treating the symptoms, not the underlying cause.
Exactly. And what's worse is that these struggles often get mislabeled as laziness or lack of motivation.
Oh, that's got to sting.
It does. It's such a disservice to these people who are genuinely grappling with a neurodevelopmental condition.
This deep dive is already showing just how important it is to look beyond those surface judgments, and really understand how these biological, psychological, and social factors are all tangled up in these so-called miscellaneous disorders.
Couldn't agree more, and we're just getting started. Next up, we're going to explore a topic that's often tough to talk about: self-mutilation.
That's definitely one that requires a delicate touch. What are the key things therapists should understand about it, especially when it comes to separating it from suicidal behavior?
That's a crucial distinction. Self-mutilation is about hurting yourself on purpose without wanting to die.
Okay.
It's not about ending life, but it is about coping with overwhelming emotional pain. Maybe finding a way to feel in control when everything else feels out of control.
It's a really complex and often heartbreaking behavior, and it really makes you think about how pain can be both a symptom and a coping mechanism.
It's true. And it's often linked with other issues like borderline personality disorder, PTSD, even eating disorder.
Right. It makes sense that someone dealing with those kinds of conditions might turn to self-harm as a way to manage those really intense emotions.
Yeah, or even just to feel something physical when they're feeling numb inside.
That makes sense. The chapter delves into some interesting research about the possible biological roots of self-mutilation, specifically those opiate, dopamine, and serotonin systems.
Oh yeah, the brain chemistry angle.
What's the latest thinking on how those brain chemicals might be involved?
Well, one theory that's gaining traction is that self-injury might actually trigger a release of endorphins, those natural painkillers we all have. And that can temporarily relieve emotional distress.
It's like they're self-medicating, but in a really dangerous and destructive way.
Exactly. And that ties into the chapter's discussion of opiate antagonists like naltrexone.
Right. By blocking those endorphins, could that actually reduce how rewarding self-injury feels?
That's the hope. And it's definitely a hot topic for researchers. But it's super important to remember medication alone is rarely the answer for self-mutilation.
You've got to treat the underlying pain, not just mask it.
Exactly. And that's where therapy comes in, helping people identify what triggers them, come up with new ways to cope, and heal that emotional pain underneath it all.
And the chapter draws these interesting parallels between self-mutilation and obsessive-compulsive behaviors. What's the connection there?
Well, both involve this feeling of an irresistible urge, this tension that builds and builds until you do the behavior.
Oh, okay.
And then afterward, there's a sense of relief, a drop in that tension.
So it's like the brain gets stuck in this loop where the behavior, even though it have bad consequences, brings temporary relief from the distress.
That's it. And that's where therapy becomes so important. It's about helping people break free from that cycle. They need to learn to recognize their triggers, develop healthier coping skills, and address that underlying emotional pain.
And the chapter stresses looking for those co-occurring conditions too, like depression or anxiety, and treating those as well. It's a whole person approach, not just focusing on the self-harm.
Absolutely. It's about seeing the whole picture.
Well, this deep dive is really driving home the complexity of these miscellaneous disorders. Tourette's, eating disorders, ADHD in adults, self-mutilation, each one's got its own set of hurdles, and there's no cookie-cutter approach to treatment.
Definitely not.
Ready to tackle the next one? Dementia-related cognitive disorders.
Bring it on. It's an area that can be a bit daunting, but there's also so much hope and new research coming out all the time.
I'm eager to learn more. What are the key things therapists should keep in mind about dementia, especially as our population gets older?
Okay, first off, let's debunk a myth. Dementia is not an inevitable part of aging.
Good to know.
While the risk does go up as we age, it's not a guarantee.
Okay.
And there's actually a lot we can do to keep our brains healthy and possibly even prevent or delay cognitive decline.
That's so important. It's not about just accepting that our brains are going to deteriorate. It's about being proactive and taking care of our cognitive health.
Exactly. It's about empowerment. And it's also crucial to understand that dementia is an umbrella term. There are actually a bunch of different conditions that fall under it, each with its own quirks and how it progresses. Alzheimer's disease is the most common, but you also have vascular dementia, dementia with Lewy bodies, and others.
So it's not just one thing. Each type needs to be understood differently in terms of symptoms and how you approach treatment.
Exactly. And when it comes to treatment, the chapter gets into the medications that are used for dementia, especially those acetylcholinesterase inhibitors, or AKIs.
Hmm.
These drugs basically boost the levels of acetylcholine in the brain, a neurotransmitter that's super important for cognitive function and tends to drop in dementia.
So it's like they're trying to amp up the brain's signaling power, kind of compensating for the damage done by the disease.
Yeah, that's a great way to think about it. And besides ACIs, there's another medication called memantine that works on different brain receptors and can also be helpful in managing dementia symptoms.
It's amazing that we can target specific brain chemicals like that to address these complex cognitive challenges. But the chapter points out that dementia often comes with other issues, like psychosis, depression, and agitation. How do those play into the treatment picture?
You're right. It's rarely just about addressing the cognitive decline. Those co-occurring symptoms can really impact someone's quality of life, and they often need their own interventions. You might use antipsychotics for delusions or hallucinations, antidepressants for mood and anxiety, and sometimes even meds to manage agitation or aggression.
So it's about supporting the person on multiple levels, not just focusing on slowing down cognitive decline.
It's about preserving their dignity, their sense of self, and their ability to do things they enjoy for as long as possible. And that often involves a team effort, you know?
Yeah.
Doctors, therapists, and caregivers working together to create a supportive and caring environment.
Well, this deep dive has been a whirlwind of information. I can feel my brain working overtime to process it all.
I know, right? It's a lot to unpack.
But we're not done yet. We've got one more big topic to tackle before we wrap up part 1. Obesity. What are the key things therapists need to understand about obesity, especially given all the oversimplified narratives that surround it?
One of the most crucial things to remember is that obesity isn't just about willpower or personal failings.
Yeah.
It's complex, and it's influenced by a ton of factors: genetics, metabolism, our environment, our behaviors, even social and economic stuff.
It's about looking beyond those judgments and understanding the whole picture of what contributes to someone's weight.
Absolutely, and that's where a holistic approach comes in. The chapter highlights how important lifestyle changes are, like eating a balanced diet and exercising regularly. Those are the foundations of managing obesity. But it also acknowledges that those changes can be super hard to make and stick with, especially in a world that often makes those efforts even harder.
Right. We're bombarded with messages that can undermine those healthy choices.
Exactly. And that's where therapy is so crucial. It's about helping people set realistic goals, address emotional eating patterns, build coping skills, and navigate all the confusing and contradictory information out there about weight loss.
And the chapter talks about medication as a tool in treating obesity. What are the main takeaways for therapists?
It's important to understand that medication isn't a quick fix, but it can be helpful in some situations, especially when you combine it with those lifestyle changes and therapy. The chapter breaks down the different medication options, each with its own way of working and potential side effects.
So it's not just about suppressing appetite.
Right. It can be about targeting metabolism, hormones, even those brain pathways involved in food cravings and how we experience reward.
It's about getting specific and finding the right approach for the individual.
Exactly. And the decision to use medication, or which one to use, should always be made with a doctor who can assess the person's overall health and any potential risks.
Makes sense. We've covered so much ground in this first part. Tourette's, eating disorders, ADHD in adults, self-mutilation, dementia, and now obesity. It's been a crash course in understanding these conditions and how complex treatment can be.
It's definitely been a whirlwind. But, you know, these miscellaneous disorders, as they're called, are anything but simple.
No kidding.
They challenge our assumptions, make us really stretch our understanding of the brain and behavior, and remind us how important it is to have a compassionate and individualized approach to treatment.
I could agree more.
Welcome back. We're in the thick of it now with these intriguing miscellaneous disorders. Before we jump to the next one, I just wanted to add something about treating obesity.
Nope.
We talked about how important lifestyle changes are, but it's key to realize that for some folks, losing a ton of weight might not be realistic, or even healthy for that matter.
That's a good point. It's not always about just hitting a certain number on the scale.
Right. Sometimes it's more about improving those metabolic markers, managing things like diabetes or high blood pressure, and just improving quality of life overall.
It's about supporting people in making healthy changes that they can actually keep up with, rather than pushing for some drastic weight loss.
Absolutely. It's about progress, not perfection.
Okay, ready to tackle our next topic?
Let's do it. What's next?
Aggression.
Okay, aggression. That's a word that carried a lot of weight. It makes you think of violence and anger. But I imagine it's a lot more nuanced than that when we're talking about it clinically, right?
You hit the nail on the head.
Hmm.
When we're talking about aggression in this context, we're
Yeah.
thinking about irritability, hostility, those verbal outbursts, and yeah, sometimes physical violence too.
But here's the thing. Aggression is rarely a disorder on its own. It's usually a symptom of something else going on, some underlying psychiatric or neurological condition.
So it's a clue,
Hmm.
a sign that we need to dig deeper to figure out what's really driving it. What are some of those conditions where aggression might be a red flag?
Oh, there's a pretty long list, actually. Think about ADHD. Impulsivity and trouble regulating emotions are hallmarks of ADHD, and those can definitely come out as aggressive outbursts. Or personality disorders, where interpersonal conflicts and difficulty managing emotions might lead to aggression.
Okay, I see. So aggression can be tied to a bunch of different things. What about mood disorders like depression or bipolar? How does aggression show up there?
In depression, you might see irritability, agitation, even self-harm as a form of aggression.
Interesting.
And in bipolar disorder, especially during those manic episodes, people can be super impulsive, have poor judgment, take more risks, all things that can lead to aggression.
And what about substance use? I know there's a strong link between substance use and aggression.
Oh, absolutely. A lot of substances, especially alcohol and stimulants, can lower your inhibitions and impair your judgment. They make you more impulsive, which can make aggression more likely. And sometimes withdrawal from substances can also trigger aggression.
Right, as the body and brain try to rebalance. The chapter also mentioned traumatic brain injury as a possible contributor to aggression. Can you explain that connection?
Sure. When the brain gets injured, it can disrupt those neural networks that control things like emotional regulation, impulse control, even how we understand social cues.
Wow. So it's not just the physical impact of the injury.
Right. This can lead to personality changes, making someone more irritable and quick to anger,
Uh-huh.
and that can come out as aggression.
It really shows how interconnected those brain systems are. So with all these different factors that can contribute to aggression, how do therapists even start to assess and treat it?
The first thing is a thorough evaluation to get to the root of the problem. We need to understand the person's history, any other mental health issues they might have if they're using substances, and what specific situations or triggers set off that aggressive behavior.
It's like detective work, right?
Yeah.
Piecing together all these different clues to understand the bigger picture.
Exactly. Once we have a good grasp on what's going on, we can create a treatment plan that's tailored to that person's needs. If the aggression is stemming from something like ADHD or bipolar disorder, the priority is treating that underlying condition.
Treat the cause, not just the symptom.
Precisely. But in situations where the aggression is an immediate danger to themselves or others, we might need to think about medications specifically for those aggressive outbursts.
What are some of the medications that are used for aggression?
Antidepressants, especially SSRIs, are often a good starting point. They can help with mood regulation, reduce impulsivity, and manage irritability. They're particularly helpful for folks who also have depression or anxiety.
That's interesting. I wouldn't have immediately thought of antidepressants for aggression.
I know, right? It might seem counterintuitive, but remember, those medications are working on those key brain chemicals: serotonin, norepinephrine, dopamine,
Right.
and those play a role in all sorts of emotions and behaviors, including aggression.
So it's about finding that balance in the brain. Are there other medications used for aggression?
Yes, mood stabilizers like lithium have also been shown to help reduce aggression. They can sort of smooth out those emotional highs and lows that sometimes fuel those aggressive outbursts.
And the chapter mentioned beta blockers. Aren't those usually for heart problems? How do they work for aggression?
You're right. Beta blockers are typically used for high blood pressure and other heart conditions, but they also have this cool effect of reducing that physiological arousal, that fight or flight response. So for people whose aggression is triggered by anxiety or stress, beta blockers can be really helpful.
It's like they help put the brakes on that intense physical reaction before it escalates into an outburst.
Exactly. By calming down the body's stress response, they can create some space for clear thinking and emotional control.
It's amazing how we can repurpose medications for totally different things.
It is, and it really shows how important it is to understand what's happening beneath the surface, not just relying on those symptom checklists or diagnoses.
Well, we've definitely unpacked aggression in all its complexities. Now let's move on to our last topic for this deep dive. Chronic pain. Chronic pain can be so debilitating, affecting every part of someone's life. What are some of the key things therapists need to know about it, especially since it's often an invisible struggle?
One of the most important things to remember is that chronic pain isn't just physical.
Right.
It's this whole mind-body experience, biological, psychological, social. It all gets tangled up.
It's not just a hurt knee or a backache. It's about how that pain impacts their emotions, their thoughts, their relationships, their entire life.
Exactly. And because you can't always see the source of the pain, people don't always get it. Sometimes they even dismiss it.
Oh, I bet that's incredibly frustrating for someone living with chronic pain,
Huh.
like carrying this burden that nobody else can see or understand.
It is. That lack of validation can lead to people feeling like their pain isn't real or important. And that just makes it even harder to cope and reach out for support. So how can therapists bridge that gap and create a space where people feel heard and understood?
Well, it starts with empathy. You have to listen without judgment and believe what your client is telling you about their pain.
It's about honoring their experience.
Yes. And then it's about helping them understand the nature of chronic pain. You know, how their thoughts, emotions, and behaviors all feed into it. Just having that knowledge can be really empowering.
Right. It's about understanding that pain isn't just a signal from the body. It's also about how our brains and nervous systems process and sometimes amplify that pain.
Exactly. And that understanding can open doors to different treatment options, going beyond just medication and exploring more holistic approaches. Speaking of treatment, the chapter talks about how surprisingly effective antidepressants can be for managing chronic pain. Yeah, that was interesting. Most people think of antidepressants as just for depression.
Right. But research has shown that some antidepressants can be really good at reducing chronic pain, especially nerve pain and pain from conditions like fibromyalgia. But the chapter makes it clear that we're not talking about using antidepressants for everyday aches and pains.
Okay, so it's not for that sprained ankle or a headache.
Exactly. This is for pain that sticks around. Weeks, months, even years.
So how do antidepressants work for chronic pain? What's the mechanism there?
Well, they work in a couple of ways. First, they can actually change how pain signals are sent in the brain and spinal cord. It's like they turn down the volume on those pain messages.
Wow, so they're acting directly on the nervous system.
Right. And second, when you combine antidepressants with narcotic pain relievers, they can actually make those narcotics work better.
Really?
So you might get better pain relief with a lower dose of narcotics, which can reduce side effects and the risk of dependence.
That's huge, especially with all the concern about opioid addiction these days.
It is, and it really highlights how important it is to have a multi-pronged approach to pain management.
The chapter mentioned that not all antidepressants are equally effective for pain. Which ones tend to be the go-to options?
The cyclic antidepressants, like amitriptyline, Doxepin, nortriptyline, and duloxetine, have the most research backing them up for chronic pain. They've been shown to work for all sorts of pain conditions: nerve pain, fibromyalgia, even migraines.
I know duloxetine, or Cymbalta, is actually FDA approved for both depression and chronic pain.
It is, and it's a good example of how one medication can have multiple uses. It just shows how complex our brains are and how tweaking certain neurotransmitters can have these cascading effects. What's interesting is that when you're using these meds for pain, you often need a lower dose than what you'd use for depression.
So again, it's about finding that sweet spot for each individual. What about other types of antidepressants? Do they ever get used for chronic pain?
Yeah, venlafaxine and disvenlafaxine, those are SNRIs, have shown some promise for pain too. They work by boosting both serotonin and norepinephrine, which are two neurotransmitters that are heavily involved in how we perceive and process pain.
Okay, and what about SSRIs, the most commonly prescribed antidepressants? Do they have a place in pain management?
The research on SSRIs for pain is a little iffy. Some studies show they help, others don't. They might be an option in certain cases, but they're not usually the first choice.
Well, this deep dive has been an incredible learning experience. We've covered so much: Tourette's, eating disorders, ADHD in adults, self-mutilation, the cognitive decline of dementia, the many layers of obesity, the challenge of managing aggression, and now the often hidden struggle of chronic pain.
And we've only just scratched the surface. These miscellaneous disorders, they're definitely not as simple as they might seem. They really make us question our assumptions, broaden our understanding of the brain and how we behave, and emphasize how important it is to treat each person with compassion and create a treatment plan that's tailored to them.
Welcome back to the deep dive. I feel like we've just run a mental marathon unpacking all these intricate disorders.
I know, right? From cystic and eating disorders to ADHD, self-harm, dementia, obesity, aggression, and chronic pain. Whew! It's been quite a journey through the human experience, hasn't it?
Absolutely. And one thing that really stands out to me is how much there still is to learn about these conditions. The research is constantly moving forward, and we're always discovering new things. It's really exciting.
I agree. It feels like we're on the cusp of a real revolution in mental health care, moving away from that one-size-fits-all approach and really embracing what makes each person unique.
I love that. But before we get too lost in the future, let's focus on what therapists can do right now to help their clients who are struggling with these disorders.
That's a great point. It all comes down to a few core principles, I think. First and foremost, approach every client with curiosity. Don't jump to conclusions or fall back on stereotypes. These disorders are often misunderstood, sometimes even misdiagnosed, because they can show up in so many different ways. Take the time to really hear your client's story to understand their unique experience.
It's about seeing the person, not the label.
Exactly. And that leads to the second principle, individualized treatment. There's no magic formula that works for everyone, even if they have the same diagnosis. The choice of treatment, whether it's therapy, medication, or both, has to be tailored to the individual. What are their needs, their preferences, their situation?
We have to honor that each person's journey is going to be different. And that brings us to the third principle, collaboration. As we've seen, these disorders are rarely isolated. They can overlap, influence each other in all sorts of ways.
Right.
So it's crucial to work with other professionals, psychiatrists, doctors, specialists, to make sure the client is getting well-rounded care.
I couldn't agree more. It's about breaking down those walls between different disciplines and creating a truly holistic treatment plan, one that addresses those biological, psychological, and social pieces of the puzzle.
And don't forget about empowering the client.
Yes, that's so important.
They are the experts on their own experience, and their voice needs to be at the heart of everything.
Absolutely. This deep dive has really shown us how vital it is to move past those oversimplified explanations and embrace the complexity of being human. It's about challenging our assumptions, constantly learning, and advocating for more compassionate and personalized mental health care.
Beautifully said. And remember, knowledge is power. The more we understand, the better we can support ourselves and those around us on their journey to healing.
That's what it's all about.
Thank you for joining us on this deep dive into the world of miscellaneous disorders. We hope you've gained some valuable insights that you can take back to your practice and help make a real difference.
Until next time, stay curious, stay compassionate, and keep diving deep.